Uh, Dear professors and dear colleagues and audience, it's our great honor to hold this Congress webinar. This session we focus on AI in heart failure. We got two Indian professors and two Chinese professors. We believe they will bring a very brilliant talk. And I think it's the advantage of AI in heart failure will help a lot in the future of we manage heart failure patients. I'm very honored to hold this session with Dr. Omar. And Dr. Omar, can you please uh, talk something, address? Yeah,
Thank you very
thank you.
much. And thank you for the invitation. So we have a very, very important session because artificial intelligence has already affected all of us and as individuals and as cardiologists. So today's session is on artificial intelligence and heart failure. And we should know that AI is a great enabler. We should not allow it to conquer us. But I'll start the session with Dr. Prayag Kini, and he will be talking on artificial intelligence in hypertrophic cardiomyopathy. Dr. Prayag Kini is one of the brightest stars of upcoming stars in cardiology in India, and I would say maybe in Asian side as well. Brilliant person, thinks differently, and that is the most important thing. The humankind improves and maybe can beat artificial intelligence in only by thinking differently. And he's one of the people who thinks differently. So over to Dr. Prayag Kini.
That was very kind, sir. Those are very, very kind words from Dr. Oman. Yes, thank you so much for inviting us. It's a wonderful session, and I'd love to be part of it. And especially because I am AI and ML trained, so I thought it was a good exposition for me also to get exposed to a kind of a global seminar. So my name is Dr. Prayag. I come from the south of India. It's a place called Bengaluru. And as I said, I've been a structural interventionalist, and I mean a rheumatic interventionalist, but also in the recent years, I've loved to apply my knowledge of AI and ML to the betterment of cardiology world. I have been trained particularly in this. That's why I thought it was a good plan to start off trying to talk about computer vision and how we really look at AI and ML in its application in HCM. So there's no disclosure relevant to this talk. As I said, I come from the south of India. It's called Bengaluru, which is also the IT capital of the world, of India at least. So HCM is a very heterogeneous disease. We know that its fundamentality is its heterogeneity because there are too many variables. There's too much of a risk variable in each aspect, whether you take strain, whether you take MRI or whatever. There's too much of diverse population across the world because people in different parts of the world might actually get affected differently and behave differently. There's very unclear history in a place such as mine, where I work in the south of India, and in many government hospitals, public hospitals in India, we don't have really genetic facilities. So, though the too high stakes of sudden cardiac death exist, we're not really getting that magic bullet where we can diagnose it. So, is really AI and HCM, since I'm starting and I'm rolling the ball here, is it really HEP, hype, or hope? That's the question I'm going to be answering. Will it assist in diagnosis? Exactly what Dr. Uman said. Is it going to take over human analysis? No, we don't want it to. Is it going to help us risk stratify individual and on a cohort level? Will it guide in managing the disease better? Or is it just another fancy hot tool with images? Let's answer this. As much as I have read and I have trained in AI, we can use this in three different ways. I'll just put it down as three different parts of a book. Number one is the AI ECG analysis. I'll be speaking about it, as well as the speaker after me will be speaking on it. AI is echo analysis in AI, and can we use it for predictive risk remodeling? Predictive risk modeling. That means, can we really get a risk model based on an AI, either on an individual level, on a family level, and can we tell them whether they are at risk of sudden cardiac death? How are
Excuse me, Professor Kini, do you share your slides?
Yeah, my slides are on there.
You can see the slides.
I guess the slides are visible to all.
Slides are visible to us.
Yeah, we can see the slides.
Shall I go on?
Oh, it's my problem?
Yeah, because
Sorry,
it is
sorry.
visible to
Go
us.
ahead.
Sorry,
Go
there is,
ahead.
sorry,
Oh.
with the permission of the chair, I'll just go ahead. So the putative benefits of using AI for HCM, well, we think that AI is going to help in early detection, improved accuracy. We can have quantifiable metrics. We have increased efficiency. That is, can we have a better diagnosis for population basis, and can we personalize care with HCM? A very, very basic, since the speakers after me are also going to allude to this, is about basics of computer vision. I'll try to cut it to very, very simple words because we are physicians. We are not really AI specialists. But we use something called as a convolutional neural network. That is the heart of looking at AI when we use it for HCM, for any diagnosis which is image based. So when we look at all the studies that have seen in terms of differential diagnosis for cardiomyopathy as a rubric, as a full umbrella, the commonest thing that we use is a CNN based analysis. That is the basics of computer vision. And very, very basic, I'll speak about this. We can use it for any of the, like any of the cardiomyopathies, though its use is maximum as of date in HCM. If we have a layer, if we have a box like this, what CNN essentially does is breaks down it into layers. It breaks it down into a red layer, a green layer, and a blue layer, and we look at it individually. How do we know this is a cat or is it a dog? It tries to get an input, tries to get into a hidden layers where we look at all of these images in a convoluted, in a intertwined manner, and then eventually gives us an output. Put simply, it is this. So if we look at a butterfly, this is something which I did myself with a code. I wrote a code in Python. I used the NumPy analysis database. This is a butterfly. We first go for a horizontal edge detection. We go for a principal diagonal edge detection, secondary diagonal edge detection, eventually give us the same kind of an output. So this is what AI does. It applies it to the ECG, for example. Like you have an ECG input, the same thing. You have a butterfly, you have an ECG. It goes through an artificial intelligence, it goes through its CNN modeling, it goes through convoluted layers, eventually gives us an output. On this, we can have millions of data sets. We can have hundreds and thousands of ECGs, which is analyzes in a fraction of a second. So we have interpretability, which is given by the CNN, and it's these hidden layers that do the job. That much is actually enough for us as clinicians to understand that this is the heart of CNN. How do we analyze it? We use it like a tool. We use an ECG, we see the clinical background. How does AI analyze it? AI analyzes it with two things. Number one is called as a saliency mapping. Salient essentially in English means the most repeating or the most defining part of an image. How do we know this is a tiger? The fur. How do you know this is a dog? Its face. How do you know this is a duck? Its wing. That is the most repeating part of an image that it sees, just as I did for the butterfly. How do you know this is a ship or a boat? It's sail. So the same thing is what it takes. It takes an input image, it has a CNN image, it has an output image. And the beauty is this. Our human eye is trained to looking at a systolic, a systolic contraction in HCM, for example. If we have a thick layer, we think QRS is going to matter. The beauty is when it was run through CNN analysis, actually, it was the diastolic corridor that was picked up, which we know now is what is the repolarization changes which dictate arrhythmogenicity in HCM. This is something that CNN picked up. We knew it, but the CNN picked it up. It was not that it sort of did not see the QRS or it was blind to it, but it picked up the subtle changes in the diastolic corridor, which made the point that it's an arrhythmogenic disease, probably because of repolarization changes, not just depolarization changes. Just as you have, and the second thing that AI uses is something called as a GradCam, where you have a class activation map, where, for example, if you want to define this as an elephant, you would look at the trunk, you would look at its body. That's exactly what it does, and it generates an image. Similarly, as is a cavity in DCM is enlarged, it sees that. As the septum and the wall is thickened in HCM, it sees that. That's how it makes a differentiation between RCM, for example, HCM, and a DCM. So this is what it uses. The hottest areas are defined as what are defining the features of that particular disease. It's been used in a lot of other things as well. It's been used in LV non-compaction. It's been used in ischemic cardiomyopathy. It's been used in simple hypertensive heart disease, and it gives different maps at different for different kind of pathologies, where the final convolutional layer will actually define what it looks like. It might sound a little tech at this stage, but then exactly why is ECG a starting feature? And this is something I think the speaker after me will also speak on. Why is it that ECG is taken as a starting feature? Because it's mostly abnormal. Whether you go across a state, a country, continents, it's very rare to find a full-blown HCM having an absolutely normal ECG. We all know that. So that's why it's the most common starting point of trying to learn AI and apply it to HCM analysis. It's very quantifiable. You see this, the normal ECG is in less than 10% of people. So most people have an abnormal ECG, and that's what it tries to pick up. Can we use it for detection of the HCM itself? Can we use it for arrhythmic risk? Can we use it for heart failure risk? Let's see a few examples. What happens to AI ECG models across all these publications that have happened right from 2019 right up to 2024 by Siontis, and Siontis is even doing it in 25. In fact, there was a very recent conference in ESC where he had published. And the AUC, the area under curve, is almost more than 90%. It's almost 90% when you have used a 12 lead data, and even when you use a single lead data. I'll actually come to this. So this was actually done by Dr. Desai from Cleveland and also from Mount Sinai. So this is more than 1 lakh patients, 1 lakh patients, of which 2.7% were flagged for HCM. An alternative diagnosis was given in almost 55% of patients. An actual diagnosis was made in 5%, which was actually correct. So the threshold of getting it is very, you have the sensitivity written down here. The specificity is more than 99%, which is whether it is intervened or not, myectomy or not, it does not matter. And this was actually a patient flags it, because if you look at it, really, this was an arrhythmic HCM actually. And you look at it, after the QRS seems relatively quiet, but when it was run through a CNN analysis, they actually found that this patient was very arrhythmic for HCM, something that we wouldn't have probably picked up with our naked eye. This was actually used in the Mayo Clinic model called as the Viz HCM model, which I'm sure again the speaker after me will speak on, because this is a new algorithm. You actually have an app where you just have to enter the patient details and it gives you the real risk of HCM. Almost 71,000 patients, of which you have identified it in 1522 patients, and they've got actually a positive flag for it. And the correlation of getting HCM as a diagnosis was 82%. Just add echo to it, it goes to 90%. For an arrhythmic risk. Now, this is something which we can individualize for every patient, right? We can actually tell them where they stand in their risk of HCM arrhythmias. And the true positive and the true negative, you see in all of this, the amount of HCM probability threshold, if we take of more than 0.95, 0.90, it's at least 90% accurate. So true positives were picked well, true negatives were picked as well. AI ECG models, can they help us in arrhythmic risk? That was a diagnosis. But can we help them in arrhythmic risk, heart failure risk, and management? Put together all of these trials, all of these studies have said that you have quite a high, 75, 90, 95% chance of pickup. And all of them, just about that, when it's seen in the third row, all of them have CNN. CNN is the heart of this, where they have cut with the images and its image edge detected algorithms. So when we see it with even just one lead, most of those studies took 12 leads. You take just one lead, the area under curve is almost 90.9 with a very good sensitivity and specificity, and it all uses this. And the beauty is in the right lower quadrant, you can see that ventricular repolarization was actually picked. That means they were looking not at the QRS, they were looking beyond that in the diastolic corridor, where they actually found out that was the one that was sort of easily going to predict it rather than the QRS itself. So an AI, if you run it through that, it's going to pick this as well. How generalizable are these models? Well, you can have it in your center, but does it work in all the centers? It's been studied. They are generalizable. Whether you do it in your center, whether you have a multi-center study and then you try it as a separate validation cohort, it works. It was tried across the world. This was something which was generated from US. It was studied in 3 different centers, in Bern in Switzerland. It was studied in Oxford, and it was studied in Seoul in South Korea. So they tried 3 different ethnicities. Is it going to work? And the sensitivity was amazing, 83%, specificity 88%, and an AUC of 0.9. So it does not really matter which ethnicity that the patient comes from. It still makes for a very good diagnosis, because when you look at it in terms of AUC, all of them overall is almost 0.92, 0.8, 0.9 everywhere. It works across the globe in terms of its accuracy. Not only does it pick it up, it also picks up in any form, any phenotype of HCM. Apical, non-apical, obstructive, genotype positive, genotype negative, all of them can be. And when I finish with my talk, I'll come to a slide where this is now done with GradCam imaging, where you can tell even the variant that it involves. I'll come to that a little later. Which are the patient cohorts where this works well in? Well, they have seen that in terms of across the 4 centers, when they saw it in terms of the US center, Mayo Clinic, Oxford, Burney, and Seoul, it was seen that the performance is best in the younger patients, where there is already an LVH by ECG, and if there is a normal, there is a relatively normal ECG for a negative diagnosis. So it can not only give you in terms of a sharp analysis, which is done, those who have it. When it is not there, you can also tell about those who don't have it. So it is when you apply it, for example, an executive who's walking into your office and you apply this and it doesn't know anything about the background, even then this can be picked up. This was actually done. This is actually a study by Milind Desai, again from US, where he speaks about a gentleman who was just going in for an office executive checkup, and this was run through he didn't know about it, his physician didn't know about it, but when they ran it through the AI ECG modeling, they actually found out that his diastolic corridor was abnormal, and they could pick this up. This was the ECG which was picked up. He was started based on treatment for this. Of course, there was a clinical analysis made after this, but at 4 weeks of mavacamten therapy, at 8 weeks of mavacamten therapy, this was taken forward by the Pioneer Old trial. I'll come to that. But this was a very initial study, only for one person. Excellent response to mavacamten. That means it was really diagnosing the disease correctly. Its accuracy was good. So when we look at it in terms of intervention, can we use it, or this is all pre-intervention? Can we use it post-myectomy, post-surgical myectomy? Can we use this? Yes, we can. Its accuracy is maintained to almost 98%. The ECG on the top shows pre-myectomy, 72% it was diagnosed. Though it was on the lower side, it was diagnosed. Then there was a clinical diagnosis made. These are people who didn't even know that they had HCM. And when it was done after myectomy, the probability still remained as 2.5. That means it has picked up that it has cured it. It can not only tell when it is there, it can also pick up after the patient is treated for it. So its accuracy both ways is maintained well with a very good AUC. So it has a super negative predictive value. It has a very good positive predictive value as well. That's what it tries to tell us. I was speaking about ECG all along. Can we use echo as a starting point? Well, it also will rely on the same kind of CNN modeling. So basically what is done is, and we have done this in our center, we have taken actually a heart model, you try to segment it, and then you put together those segments. It's like doing integration and differentiation, which we learned in maths. It's as simple as that. So when we integrate it all together and we see it in terms of, you optimize your image and then you do from each layer, you can actually detect it well to almost an AUC of 0.851. So this was teamed up with the ECG to see if it's any better. And they have found out this is, as I said, this is also going to use CNN modeling. So when this was teamed up with an ECG, the accuracy was phenomenal. So this is the trial I was actually mentioning. Can we now have a human touch to it? Can we now go for what we know? Can we combine the data that we know about clinical, the echocardiography, and the biomarker data? Does it help? So the Pioneer trial essentially was a trial of mavacamten when it was extended to an whole arm, where you have seen in terms of the Pioneer Old trial was basically, he tried to see in terms of ECG enabled diagnosis. If you make an HCM diagnosis and you start treatment for it, does it work well? Let's see what happened. You can see that this was done with an external validation. It was not just in their own center. It was done with the control data. It was done with external validation, and it works extremely well. These are 50, 55, the mean age is 57. So these are people who are, likely to be having a risk of HCM and even HCM related deaths. So what happens when you diagnose AI with HCM? HCM with AI, and then you treat and you see the gradients. Does it really amount to accurate data? Excellent data. In fact, when you go with AI-based diagnosis and eventual treatment, this could be something for the future. Again, as I come back to Dr. Oomen's words, are we taking out the clinical part of it? No, we are not. Because on a larger scale, particularly for larger populations that China has, we are going to definitely look at it in a clinical aspect. But when you apply it, for example, you go to a mobile hospital and you run through another 1,000 ECGs. Can you pick this up? It is accurate. Because everything came down. The UCSF score came down, the Mayo score came down, LVOT gradient came down with Valsalva maneuver, and NT-proBNP came down. So that means an AI-based diagnosis of HCM was accurate. It was not that it was not giving response. You could see the response. After the response, the AI improved. Even that was picked up by the AI. And this all calls for exciting future. This calls for a future in the sense that this is what I was saying. When you go with something called as GradCam images, you can actually image now. This is looking forward. This is a gene-specific determination by way of echocardiography findings. That means you have an echocardiographic image, and at the end of the image, you see in terms of discrimination. Can you discriminate these images in systole and diastole and can you tell about the variant that the patient has? Now, this is many steps ahead of what we have been speaking till now. This can be done. And the beauty is that this works better with diastole than systole. You can actually give MYH gradient, MYH variant is there or MYH variant is not there. This is a plaque view, for example. The deeper the highlighted picture, that color, if it is highlighted, the more relevant it is for a particular class. And it has been studied. This is very, very recent data. This is 2025 data. And it has been studied that in MYH7 or in a myosin in a binding protein C3 or in a troponin mutation, you can actually see it different between in the systolic and the diastolic images, close to an accuracy of 100%. This is work in progress. This is something which has come out very recently. As I said, it's still to go ahead. So you can actually see it in terms of systolic and the diastolic frames and whether the kind of differentiation that it makes. So this all calls for a very, very different approach to looking at HCM. HCM is a very mortal disease, and sometimes you don't even pick it up unless the patient comes to you with a first episode of a VT or having survived a sudden cardiac death. You might also have the need to pick it up in the relatives of those people who are affected. It's not very easy to get genetics. It's easier at some point in time with the kind of AI analysis we have on echo to integrate all this in the same echo machine. Our vendors can take it up. That's all for the future, of course. But if some vendor takes this up, maybe you could do this as part of the echo and then classify the patient at whatever risk he stands. So there are challenges. I have worked with AI. That's why I'm saying, the biggest challenge that we face in AI is garbage in, garbage out. That means if you have an input which is not good, if you have fuzzy images, if you do not have good echo images, I totally agree that this might go haywire. So you need to have a good amount of data to come in, input data, to have a good accuracy of the algorithm, and eventually to have a quality and quantity of training data that you're going to give in your validation, right? Because if your training data set is not going to be right, your testing data set is not going to show it well. Ethical considerations, of course, because we still have a lot of HIPAA, a lot of patient transparency that needs to be maintained, data transparency that needs to be maintained. And as I said, clinical validation, though there was one study which saw 4 different ethnicities, I think overall it requires a lot of clinical validation also. We cannot take this away from the clinician. It's just a tool for the clinician to diagnose something a little more easily and more thoroughly. It might require validation as it goes through. I'll just conclude by saying, as I said, I started, is it HEP, hype, or hope? So like a signal, I put it as red, yellow, and green. I think it's hope. To my understanding, it's hope. It assists in diagnosis. And that's the next topic, AI-enabled diagnosis. So it assists in diagnosis. It's not here to replace human capability, number one. Number two, there's a large volume data you can analyze. You have looked at 1 lakh ECGs. How often do we look at 1 lakh ECGs really? And when you pull it from multiple centers, and you run it through an algorithm, there is definitely going to be less fatigue factor with more amount of accuracy. Applicability has been demonstrated that you can go across ethnicities. There's a common language that we can all speak. You don't need to speak Korean and English and Swedish and English. We all speak the same language because language has no barrier, disease has no barrier. And globally, this is something that it can overcome barriers. As I said, genetic testing is still difficult. I'm sure Dr. Uman and Dr. Buggy will both agree. In India, it's quite difficult to get in most centers, in public centers, to get this. Can this become a science of tomorrow? Yes, it can. You probably need to include it as part of your echo analysis when you have unclear clinical data. Though, of course, it can be powered for them as well. Thank you so much. This is my lovely hospital from India, and I welcome you all to India when you come down. Thank you. I hope I've not overshot time.
Perfect. I request Dr. Sindhu to introduce the next speaker.
Oh yeah, thank you, Dr. Oman, the Dr. Kenny, just a very brilliant talk. So we welcome the next speaker from Tianjin Medical University, Professor Liu Tong. Tianjin Medical University is one of the largest hospital near Beijing. And Dr. Liu is very well recognized all around the country, and he is an expert in many areas. He is very, especially well known in the new technique, and maybe he will bring another perspective from Chinese clinician as to the AI enhanced ECG for diagnosis of cardiomyopathy. Professor Liu Tong, 还有
Okay, thank you very much for the invitation. So, can you see the screen?
Not at. Yes.
Yeah, it's
It's
okay.
okay? Okay. Thank you very much. So thank you very much for the kind invitation for let me talk about a very interesting topic about AI-enabled ECG in diagnosis and detection of hypertrophic cardiomyopathy. And I think Professor Nikki has already have a very excellent talk about this topic. And I think there are little similar overlap between our two talks, especially the AI ECG in the detection of the HCM. So as we all know that recent years there's many kinds of method to can collect our ECG data. Use the different kind of hardware and software, and what we can use the AI ECG in our clinical practice. We can screen the cardiac disease and diagnosis disease and evaluate the prognosis, the disease and treatment and management and long-term follow-up. And there's already some studies already published regarding the AI ECG to have can predict atrial fibrillation, ventricular arrhythmia, and aortic stenosis, and heart failure, and also as well as the hypertrophic cardiomyopathy. That's today's topic. And every day, now that we collect a lot of ECG in our clinical practice, and how can we use all this ECG data in our clinical practice in the measurement of our clinical patient is very important challenge for our cardiologists. And as we all know that there's already a lot of the ECG database to help us to develop the AM ECG application. And as we know that there's a lot of well-known ECG database, such as from the Mayo Clinic and from the UCSF and also Cleveland. And also there's already two very important from China. One is Professor Xiaoyun Wang. Xiaoyun Yang is also very good friends. He established ECG database from the Huazhong University of Wuhan, and the other is from the China Physiological Signal Challenge 2018 database. And for the hypertrophic cardiomyopathy present a very complex diagnosis and prognosis challenge for all our cardiologists and internal medicine doctors. And because this the heterogeneous phenotype and is the difficult to the management of the clinical course, and this as we all know that there's a lot of this different treatment on the hypertrophic cardiomyopathy, and also there's a lot of different methods to help us to early diagnosis this disease and help us how to management of this kind of patient. Regarding to the detection of HCM use AI-enabled ECG, one of the first paper from the UCSF published as in the 2018 and 19, and in this ECG data, 1,000 ECGs from the UCSF, and they develop 4 models. One of them is HCM detection model. You can see this AUC area already at 0.81, and you can see there's another models. For example, the pulmonary hypertension detection model and amyloid detection model, also very high AUC. And the second one is very important and very well known, is just mentioned, and from the Mayo Clinical is 2020, and this model they use more than 3,000 patients with HCM and more than 63,000 controls ECGs, and they develop and use the CNN model to develop into HCM the detection model. They use the training cohort and validation cohort and testing cohort. And there's the specific more than 91. You can see there's very high specificity and sensitivity, and also more than 80, 87 and 91. So, and this are from the Mayo Clinical, and this one of the case, this patient before myopathy and the HCM probability is the 72%, and following the surgery, and they probably, and also the colleagues from the Mayo Clinical, they use this model to the children and adolescents and so young patient with HCM. You can see there's also very high specificity and sensitivity, and even higher than the elder model, the AUC you can 98. And you can see, and in this part of patient with very young aged patient with HCM, and this kind of model is maybe very well useful in this kind of patient. The other thing is, I think, very important. We need a long-term follow-up of all this patient. So the long-term treatment and the long-term follow-up is very important for HCM patient. So in this study, they use some premier OLC clinical trial HCM ECGs, and also some ECGs from the UCSF and Mayo Clinical method with the controls. They they developed a very long-term follow-up. They checked AI ECG algorithm, the performance in the long-term analysis. And you can see for this 13 patients, and they use different kind of treatment, and you can see the ECG can help us to predict the LVOT gradient with Valsalva and predict the changes of NT-proBNP of this patient. So I think in the clinical practice, we can use the ECG to evaluate the treatment effect on all these kind of myocarditis and for example ablation, catheter ablation, and alcohol ablation and surgery for all these different kind of invasive and drug treatment of the HCM, and how the performance of all these patients. So this they collecting different ECG with the different scores, AI scores, UCSF scores, and Mayo scores, and you can see that all this score is well performance in the poor treatment is use poor treatment ECG and early treatment ECG and late treatment ECG. They can help us to evaluate the treatment effect and treatment performance of all these patients. So, this just published a paper on the AF-ES ECG. They use the international cohort and use Berlin and soil and from the East Asia, and three places in England, and they checked the poorest Mayo Clinical ECG model. They check their performance and all different parts of all these different population, East Asian and white and black people. You can see that in Berlin, Oxford, and so there's all very good AUC models, AUC result, and you can see that in this special kind of the disease, they have very well high AUC compared with different others cardiovascular disease models. You can see there's also see that the patient with HCM and compare with controls. There's a different kind of ECG markers, parameters, they can difference. And I think the ECG of hypertrophic cardiomyopathy is very unique compared with the other and compare with controls. So that's maybe the reason why the AUC and very high compared to previous AI models. You can see that for the different kind of HCM, the apical HCM is the highest AUC ROC compared with the non-apical HCM. So as we know that for the ECG reader, electrocardiologist, we very compare easily to find out which one is the apical HCM. Use the find T-wave inversion with the wave 4 to wave 6, and you can even be better than the echo to detect the apical ECG. And this the like a device developed from the Mayo Clinic. This device is already following this study. It's already approved for the first device in from the FDA, and they can use to detect the hypertrophic cardiomyopathy in clinical patients. So this another one from the MGH to check this kind of device can use during clinical practice. You can see that's a very high AUC is a 0.975. So this kind of device is following this study. This kind of device is already approved by FDA. I think this, as far as I know, this is the first cardiovascular machine learning based notification software device approved by the FDA. So this some the sample case ECG cases from this study. And the other is what about the real world AI-based ECG analysis to diagnose the HCM. This from Cleveland cohort. They also have the very good performance in the different kind of different populations, and there's no significant difference in the AI ECG performance in different subgroup of patient. For example, there's men at the different sex and male toxicity or not, and use mavacamten or not. There's also good performance. And it's a very important things we must know that to diagnose the hypertrophic cardiomyopathy. For this paper from the Goto and published in the 2022, combined with the AI ECG and the model, and they use this to the three cohort to check this kind of method. For this machine learning models, they use the AI ECG combined with the echo is a much more better performance for the expert. Even for the expert, you can see that there's also there different kind of the HCM cohort, MGH, UCSF, and TIGO, and BWH, and they use different the cohort, HCM cohort have well performance. The other study from China is Professor Jiang Chenyang from the Zhejiang, and he established a CNN model to evaluate the AI ECG in 1,024 HCM patients, and with genetic testing. And also, the AI ECG can help us to predict which kind of genotype the HCM. I think the ECG may help us not only for the diagnosis of the HCM, and also can help us to know which kind of the gene mutation of the HCM patient. And the others, the AI-ECG can help us to classify the hypertrophy heart disease. They can help us to classify which one is the cardioamyloidosis and which one is the aortic stenosis and which is the HCM or other hypertrophic hypertensive left ventricular hypertrophy can help us which kind of the hypertrophy heart disease, and also it can help us to identify some patient with high risk of HCM. You can see this the model can help us to find which the following four cancers of the high risk patient of HCM. For example, the systolic dysfunction, massive hypertrophy, apical aneurysm, defined by the AI-ECG. This review is just published this year, and they just completely comprehensively reviewed all the studies regarding to the AI-driven ECG and in the hypertrophic cardiomyopathy management. And as such, suggest our audience can download this review and to read that. I think it very help us to know that the AI-ECG model can help us to detect the HCM, also help us to predict the arrhythmia risk, heart failure risk of HCM, and also can predict the management of HCM, such as for now, the mafecatin is widely used in our clinical practice also in China, and which kind of patient the treatment effect of mafecatin maybe help us to predict. And in the future, I think the final slide in the future, I think the AI-ECG still a little bit complicated because all our patients maybe have the multiple medical conditions. For example, a lot of the comorbidities. For example, in this case studies from Mayo Clinical, they use AI-ECG, the changes of this ECG, and with the different model combined together, can predict for that patient their medical condition changes. For example, from this period, there have very high probability of cirrhosis, and after following the surgery, and then from time going on, there's the very high risk of AFib. Maybe the AFib can be ablated, and also they have another disease. For example, the patient may have multiple disease, and also have new developed disease, and in the whole life. So the ECG and AI-ECG can help us to predict a different kind of disease combined together in one patient, and also the following our treatment of disease, that disease the probability decrease, and some for the timing going on, the other disease and can the probabilities can increase. So this can help us for the long term to moderate the patient with the different kind of disease. So I think in the future, the AI-ECG is not just used in the cardiovascular disease, also can help us use in some other non-cardiac disease. For example, there's just published a paper for AI-ECG can help to predict predict the cirrhosis and hepatic failure for other liver failure, for example, liver disease. So other different kind of disease. So maybe can not just for for Cadvan's disease. And I think that's the future of the AI ECG. Finally, for our audience, maybe can just some one of our book just published this year. It's called AI Augmented ECG Technologies by Springer, and also the second edition of our AI ECG book in Chinese will publish this year. This our WeChat code called AI Heart. Thank you very much for your attention. Thank you.
That was
Thank you.
wonderful. Yeah. Go ahead, Professor Singdu, and I will take over.
No. Thank you so much. That's very inspiring. And Dr. Omar, you please.
Okay, so I have great pleasure in inviting Dr. Bhagirath Raghuraman. Is one of the senior office bearers of the Heart Failure Association of India. He's a brilliant interventionalist, structural specialist, and he has done pioneering work in chronic thromboembolic pulmonary hypertension. So, and also he's very much up to date in the modern technologies, and he would be that person to talk about artificial intelligence in heart failure. So from specifics of hypertrophic cardiomyopathy, we go to the full-fledged to heart failure. Over to you, Dr. Bhagirath.
Thank you, Dr. Abraham. Good evening, everybody. Greetings from Narayana Institute of Cardiac Sciences, one of the largest cardiac hospitals in Bangalore. We do something like close to 100 cath procedures and 50 open heart surgeries every day. So greetings from my institute, and without much delay, I'd like to start off with my topic, role of artificial intelligence in heart failure. I once again thank the office bearers and the team of this conference for having given me an opportunity to speak in this elite forum. So I'd like to give you an overview of artificial intelligence. I'm sure Dr. Prayag and Dr. Tong Liu have given in detail about ECG and echo. I thought I'll utilize the time allotted to me to see where all AI can make a difference in terms of the diagnosis and management of heart failure. So basically, if you're looking at artificial intelligence, it's the simulation of human intelligence in machines. It can throw up diagnosis, and as rightly pointed out by Dr. Prayag and Dr. Abraham, it cannot replace human intelligence, but can work together with that to give more gratifying and better quality results. The types of AI that are relevant to healthcare include machine learning, deep learning, and natural language processing. And role in medical diagnostics and predictive analytics have now taken center stage because AI has a very, very big role to play in our day-to-day lives. So to give you an overview, we have the data assimilation, we have the training, we have the foundation model, and the downstream tasks, which include clinical note composition. It can help you on your day-to-day rounds. Patient-friendly discharge instructions. You can have chat bots that can answer questions at the time of discharge. You don't need to be physically present there. The disease detection, classification, and treatment, which helps us in a very big way. The chatbots, which is entered by the patient, gives us the raw data, and we can process it along with our clinical acumen. Image segmentation, chatbots for patient questions, the clinical trial matching. Supposing you're doing clinical trials and in your busy practice, you don't have much time to see which are the patients that might meet the criteria of your clinical trials. They can bring up the patients in your patient profile in those who have registered for you. And also literature search and summarization. So if you have a topic, it can summarize the published data to help you to come to an understanding on the current concepts. The applications include that it can improve the diagnosis, management, and outcomes. It has got AI-based numerous tools which help in disease detection and diagnosis. It helps to create optimized treatment plans. Now, each patient is different. Each patient profile is different. The way the same drug works in different patients is totally different. So you can have tailored therapies, meaning you can customize the treatment according to individual patients. You can see which are the drugs which are more likely to act in patient A vis-a-vis patient B, and focus on tailored therapies that are likely to help those patients. It also helps in improved patient monitoring, both as an inpatient mode and a remote mode. In a country like India, which is very vast, visiting hospitals on a regular basis becomes quite challenging for patients who are in Tier 2 and Tier 3 cities. So for them, remote monitoring has come up in a very big way. Our nurse practitioner can keep in touch with the patients, and they can send in the raw data, which AI can work on and tell us whether this patient needs attention or can be managed by the physician assistant without disturbing our day-to-day routine. Also, risk stratification and prognostication. Which are the patients that you need to pick up for more urgent and specialized care across the spectrum of heart failure? So all of these can be managed by AI, inbuilt AI in your day-to-day management. That is, we have included it in our hospital EMR. So it is able to pick up based on the entered data, which are the patients who need more time, more attention, and more attention to detail. So these things can be easily picked up. Now, role of AI in heart failure has gone a long way in the early diagnosis using imaging and biomarkers. Oftentimes, the imaging and biomarkers are analyzed by the AI, and they are able to pick up stage A and stage B heart failure, which at a clinical stage may be difficult, but these are immediately shortlisted for greater attention because these are the stages where you can make a difference and alter the course of the progression of heart failure. So in that way, it makes a very big difference. It can predict the risk of hospitalization and mortality, in-house mortality or in-hospital mortality. So these are the patients who require more round-the-clock attention, more aggressive treatment, and also goes a long way in counseling the family regarding the seriousness of the patient and what are the measures of what are the likely options for us given the patient's condition. Personalized treatment plans, as I told you, each patient is different, and this helps us to draw personalized treatment charts according to each patient profile. And of course, wearable devices have come up in a very, very big way, and there are devices that can monitor each and every parameter. So these send it to the AI center, which then assimilates this data and is able to tell us exactly where the patient stands in the journey of heart failure. So this is a model of how the whole things work. You have the training data set, you have the test data set, you put it in the predictors, you have numerous algorithms, and then you have the various parameters like feature selection, training, cross-validation, model assessment, external validation, and then this is able to give you the outcome prediction. Based on this, you can come to a conclusion regarding your patient. Then predictive analysis. The AI models can predict likelihood of heart failure onset, the readmission risk, disease progression, and machine learning models have come in a long way to analyze patient records, labs, and vitals. Use of AI algorithms on echocardiograms and MRI. I think already Dr. Prayag has highlighted this. We also have included MRI. So you have software in our system which can immediately pick up patients who have both heart failure with reduced ejection fraction, reserved, mid-range ejection fraction, and pick them up for more aggressive monitoring and care. There is automated detection of heart function abnormalities and faster and more accurate than traditional methods for diagnosing these patients. Now, this is a snapshot of how the AI helps in various stages of heart failure. I just said that in stage A, you have chatbots. This can be filled up by the patient itself. You don't really need people over there. There are sensor-based outpatient risk screening factors, continuous surveillance. Then you go to stage B, where there is screening of patients with asymptomatic LV dysfunction. Stage C, the cardiomyopathy diagnosis, which has been already dealt with in greater detail. And of course, stage D, advanced heart failure, wherein what are the options as per the patient profile. Now, why do we need artificial intelligence? So these are the various phases or stages in which AI can help. You can look at clinical risk predictors of heart failure, the lagged phase, early institution of GDMT, who needs how much, at what dosage, and when exactly you can titrate it. Research database building, MCS monitoring. This is another challenge because you may not have trained personnel everywhere. The AI helps to assimilate the data and can guide you how to manage. CRISPR, ECG risk models, echo models, wearables, which are there in a very big way, implantable hemodynamic monitoring. It can throw up data regarding how aggressively you have to manage the patient, when to escalate and when to de-escalate. And of course, it is a matter of conjecture at this time regarding the future. Can it really cure heart failure or at least control it to a great extent where it is no longer the challenge that it is today? Now let's look at supervised, semi-supervised, and unsupervised AI learning. All of these are integrated. You have the description given here, summarized to say that it is inbuilt in the various machines. It can detect the data as you're analyzing the patient and throw up the diagnosis based on the data that you have entered. It can be supervised, or it can be semi-supervised or unsupervised. All said and done, it is able to bring out data that you probably may not even have looked for. And putting this together, it goes a long way in assessing the severity of disease in your treatment, in your patient, wherein he may otherwise be asymptomatic. So this is a more detailed description. The supervised learning includes classification and regression in these various models. So also the unsupervised and the semi-supervised models. Next up, what is deep learning? The rapid growth in a subset of machine learning is known as deep learning, and this has had an astonishing rate of growth. It is multi-layered, just like the human brain. And you have the cartoon below showing how at various levels it goes deeper and deeper, so that you get a fantastic in-depth knowledge regarding the patient profile and how exactly the disease is progressing and where you can make a difference to the patient. Personalized treatment, I already told you that apart from tailoring medications based on patient-specific data, you can adjust doses on a day-to-day basis. It tells you whether to escalate or de-escalate, and you can alter this dynamically. It reduces the adverse effects and it improves outcomes because you can de-escalate when exactly you know that you're losing the game in terms of the side effect profile. Remote monitoring and wearables. This has come up in a very big way. AI-powered devices can track the heart rate, the rhythm, and the fluid status. They are able to alert the patient. There is a central database wherein all this data is assimilated, and immediately you get a physician alert, you get a nurse practitioner alert, and you get a central alert from the patient's device saying that the patient needs immediate medical help, if necessary, dosage adjustment. Otherwise, more aggressively, the patient may require hospitalization or at least a hospital visit to prevent a hospital admission. It alerts healthcare providers of early signs of decompensation, enables timely intervention, and reduces the hospital stay because it's able to tell you when your patient is ready for discharge. The published literature regarding how AI can help. Now, what I plan to do in the next few minutes is to tell you various segments how AI can help in various patients. It can help in the diagnosis of heart failure. This is the random forest classifier. This is based on the ECG. I think the previous speaker spoke in detail, but suffice to say that you feed in the raw data, and then the test data and training set are the next steps in terms of the analysis. Then it builds the random forest profile, and then it helps to predict whether this patient is in line for heart failure or is not so much a candidate. And accordingly, you can intensify the level of management. The EAGLE trial, again, diagnosis of heart failure from the ECG. This is again AI-guided screening for low EF. The whole summary of this is you can pick up patients based on the ECG profile, particularly in the low EF, and you're able to predict outcomes, saying that how exactly this patient is going to fare over a period of time based on serial ECGs. And that again can make a huge difference regarding how you manage this patient and how to prognosticate this patient from the point of contact. Echocardiography-based algorithms, again, a lot of it has been done in greater detail. Convoluted neuronal networks accurately identified various views. The cardiac structure measurements can be taken, and based on this, more predictive analysis is possible. Automated ejection fraction and longitudinal strain measurements. This is again automated. So this throws up, as soon as you finish the measurements, the AI-generated model will throw up where exactly the patient is in terms of the heart failure journey. Trained CNN, to detect hypertrophic cardiomyopathy, cardiac amyloidosis, and pulmonary hypertension. All of these can be obtained in great detail and can make a very, very big difference in terms of patient management. So this is an example of the LV strain imaging. We have this model built in our hospital ecosystem. So once you enter the raw data, it is able to tell you which are the patients who have early stages of heart failure, and accordingly, you can intensify the treatment for such patients. Next is the EchoNet dynamic. This is the diagnosis of heart failure from the echo. This is Ouyang et al.'s the paper. What I wish to highlight based on this paper is how it can be adapted to a setting like our country. Video-based deep learning algorithm. The segmentation of the left ventricle. I'll just show you how exactly the segmentation is done. Assessing cardiomyopathy and estimating the ejection fraction. In an external data set, EchoNet, that is dynamically predicted ejection fraction with an absolute error of 6% or even less, depending on where exactly the measurements were taken, and identified HFrEF with an area under curve of 0.96, which is really excellent for a machine-based interpretation. Now, importantly, to adapt this in a community scale, the healthcare worker can do the echo in a remote area, and these can be uploaded. And the machine-based learning is able to pick up from a huge data set of patients who exactly are the patients who need to be managed differently, who are the patients who need more aggressive care, which of the patients need to meet a heart failure specialist in terms of more aggressive management, and of course, risk factor modification, and how exactly you can prevent the progression of heart failure in such patients. Now, this is L-shape analysis. You can see the regional curvature. So you can, as I told you, you can break it down into segments. And then the good thing about these segments is each segment has got its own dimension. It's got its own value, volume, and the overall function. So you can have segmental analysis, and you can summate all of this using AI to tell you the complete ejection fraction of the patient, which is highly accurate, almost comparable to the other imaging modalities like an MRI and so on. This is the right ventricular assessment. Both the 3D echo in LV and RV are placed alongside. What is done is in a net or a mesh-like form, the ventricle is segmented, and you can analyze each of these segments and summate it to give you the most accurate assessment of the LV function and RV function. Next is the fully automated echocardiogram interpretation in clinical practice. This is another paper presented by Zhang et al. So machine learning algorithms are able to identify patients who benefited from personalized therapy and whose prognosis can be more precisely described. It is utility of CNN-based models for risk-based classification of heart failure. It is also able to identify phenotypes like HCM amyloidosis via the trained models. How it can AI can also help to monitor the response to treatment. So the GDMT in a country like ours, where follow-ups may be difficult and challenging, the GDMT, that is guideline-directed medical therapy, including titration of doses and escalation and de-escalation, can be AI monitored. There is a huge evidence for CRT responders using AI models, and also the SMART AV model for short-term CRT response. So all of these help in a very, very big way. AI also monitors the therapy for heart failure, the LINK-HF study. You can get clinical alerts post-discharge regarding how your patient is doing. It detects clinical worsening with a 76 to 88% sensitivity and 85% specificity, which is excellent, and immediately picks up the patient who needs to come in much earlier than his scheduled visit so that you can monitor and modify the treatment. Median time alert between readmission is about 6.5 days, which is excellent. AI can also help to provide prognostication of heart failure. So these are the various trials which have shown how AI can help to prognosticate. For lack of time, I'm not getting into the details of this. In the management of heart failure with preserved ejection fraction, this is a snapshot of how complicated heart failure with preserved ejection fraction can be. There can be many, many comorbidities. There is a heterogeneity in terms of patient profile. Within the same patient, there can be multiple profiles. So if you're able to use and harness the power of AI, you go a long way in terms of how exactly to detect and manage heart failure with preserved ejection fraction. So the key applications include automated chamber quantification, diastolic function assessment, strain imaging, and pattern recognition. All of these are excellent parameters wherein you use this to identify first, pick up your patient with heart failure with preserved ejection fraction, how exactly the patient profile is, what is the likely severity, what are the outcomes, and so on. The ECHO-GO model. This is again a wonderful model. So based on the echo, the echo itself, once you enter the parameters, it uses the ECHO-GO model, AI model, and immediately as you're doing your measurements on a clinical basis on a day-to-day practice, it immediately shows up which are the patients who have heart failure with preserved ejection fraction, so that you can pick them up and manage them more aggressively and manage them differently. Another one is the stepwise phenotype-based approach to heart failure with preserved ejection fraction. So the stepwise management includes confirm and the presence of hallmark heart failure phenotypes, confirm preserved ejection fraction, additional evaluation of common cardiac phenotypes, and evaluate common extra cardiac phenotypes. So these are the 4 models. This is more advanced AI, and the accuracy of this is fantastic because you're looking at multiple parameters, multiple echo parameters. The vascular, pulmonary, renal, metabolic, and skeletal muscle parameters are also included, so that your accuracy of diagnosis is almost on par with the best standards in the world. This is the pheno mapping models. So this is against the published data. So you have three various levels, that is hierarchical clustering, partition clustering, density-based clustering. So suffice to say that these are from the elementary level to the more advanced level, how exactly you can phenomap heart failure with preserved ejection fraction. In cardiac transplantation, which is our area of expertise, we can match the organ donors and recipients better. We can increase the number of usage of organs, that is marginal donors or recipients can be picked up, prevent organ rejection, because biopsy at level 1 and level 2 can be done by the AI machine itself. You don't really need a trained pathologist. It helps to interpret biopsy slides, and also precision drug dosage and delivery through personalization is possible for each transplant patient. Now you have this Heart in Box, which is a TransMedics revolutionary point of care. So this is the way organs can be transplanted across huge distances, because you have AI models which give updates on the health of the heart graft, the analysis of real-time parameters. It throws up the biochemical parameters, the heart rate, the ejection fraction, and it also gives you ischemic time alert, how far we are or how close we are to the maximum ischemic time. And you can correct various variables so that the organ remains usable. At the level of physician care, many of the physicians are intimidated. So these are the various techniques by which you can make AI more friendly. At a tier 2 and tier 3 city, they are intimidated by the role of AI. But all that we need to tell them is how we can harness AI to our advantage and use it on a day-to-day basis. Advanced level diagnostics, the CardioMEMS device, this is again implanted to pick up the mean PA pressures, and also give us how the pulmonary pressures are. Suffice to say that it's important because it can pick up heart failure much earlier and prevent a hospitalization, and you can tell the patient on the phone how to go about it. The REDS wearable device, it is a cleared wearable for class 2 grading and detection of pulmonary congestion. We are using this in our hospital. When the patient tips the balance, you are able to detect this patient and prevent a hospitalization. It just needs 90 seconds on an OPD basis to do this. Lastly, we have a robotic soft total artificial heart, hybrid heart. So the patient's parameters are first taken in. The AI model generates how the heart should be for this patient. And based on this, you can construct separately the right ventricle, the left ventricle, and the septum. And this goes a long way. Lastly, some challenges: data privacy, real-world model preference, trust, large diverse data sets, integration, fairnesses, and biases. These are all part and parcel of AI models, and we are working on this. Though the era of machine learning and imageomics and wearables is coming up in a big way, patient data safety, the privacy, accountability, regulatory or cyber security, the patient data may be stolen. So all these pose challenges, and there are workarounds for all of these. Future directions: combine it with genomics, enhance real-time monitoring, improve patient engagement, and AI develops with clinicians. These are the future directions. Huge number of options available. This is the summary of my talk. Conclusion is, it's here to stay in a very big way and can revolutionize the management of heart failure. Thank you everyone for your attention.
Thank you. Thank you for this great talk, and we look forward a promising future with the AI in the management of heart failure. Thank you again.
So in 30 seconds, I would try to summarize what I learned, and then over to Dr. Sindhu, and then if there is time, we'll have some questions. So the most important, the key points are: one, AI is useful for early detection, and you can use algorithms in ECGs, echoes, chest CTs, wearables, implantables to pick up patients early. Two, risk stratification. The machine learning models predict hospitalization and mortality risk by integrating the health records, imaging, and even lab data. Three, remote monitoring. And we can pick up early. We can use the voice of the patient, photograph of the patient. And there's a very recent publication about foot scanners, which can pick up edema and before at least 13 days before hospitalization. 4, personalized therapy. Like was mentioned, we can predict response to CRTs and ICDs. 5, clinical decisions regarding therapies, medications, titrations, and reduce medication errors. Still, medication errors is a major challenge. Mobile health innovations, number 6, is also coming in a big way using smartphone, spectacles, etc. Few words about the challenges. Data quality. I totally believe in garbage in, garbage out. So we have to have the proper data. And also, I personally face with challenges of ChatGPT hallucinations where it makes up data. And also transparency issues, regulatory hurdles, all these barriers are to be taken care of. Over to Dr. Sindhu for her comments.
Professor Omar, you got a very excellent summary, and I believe engineers from India and China are the best engineers in the world, and I hope in the future we can join together. We have the largest population in the world in our both countries, and we have the largest data of ECG and heart failure patients, and so many things we are similar and we are neighbors. So we hope we can join together under the leadership of Asian Heart Society and work together to fight for the heart failure and the cardiomyopathy. I look forward to welcome you to come to China to the Great Wall meeting someday and meet you in person. Thank you so much.
Thank you very much. We are just over time. So with your permission, we would close the session.
Yeah, thank you. Thank you, everyone. Thanks
Thank you.
for the
Thank you.
Thank you very much. Thank you.
Thank you.
Thank you.